So I can't quite hear you guys. I'm not sure. It's an iPhone. Probably need to unmute yourself. And I see a Tiffany on here. Tiffany, can you hear me okay?
Yes. Can you hear me?
Yes, I can hear you, Tiffany. It's nice to meet you. Thanks for joining us.
Thank you.
I'm going to wait for a couple more people that registered to come on board, and then we'll get started. It might be a small group tonight, which is nice. Sometimes it's a nice intimate group. We can really ask some questions and get into
Okay.
And Tiffany, you're seeing me right now, right?
Yes.
And then I know somebody else is here. I think I just responded to your message there. I can hear you, I believe. You're on an iPhone.
Yes. Yes.
And what is your name? I can see you. Melanie,
Okay,
nice to meet you.
Okay, good.
I can hear you. Let me increase my volume a little bit so you
Great.
guys can tell. We're going to start in just a minute. I'm going to give just a couple more minutes for people to kind of to get in on the call.
I have a question for you. So do you actually see me or just a image of me?
I see an image of you.
Okay, got it. I'm not sure why but it's okay, right?
Yeah, that's fine. Whatever you're comfortable with. As long as you can see the presentation, and we'll do a lot of demonstration tonight. So it'll be pretty interactive, and it will be a small group. So you guys feel free to ask questions as you need to. And I'll give plenty of time to, I'll stop in between sections and let you guys ask questions if anything seems confusing or needs clarification. They'll do that as well.
First time I'm using Zoom, so
Oh, really?
yeah.
Yeah, it's almost essential nowadays where everything is on Zoom now.
But it's kind of scary at the same time because I heard that you know, they are spying on us or something like that via Zoom. So
yeah, supposedly they have taken care of all those security hackers, but you never know. I don't think anything is foolproof. So hopefully you guys received the handout that goes along with this presentation. It's just a little handout to kind of keep you engaged with the presentation. There's some fill in the blank there. So you guys can fill in. I will talk about each one of these points. I think there's 7 points on there, and that you guys can follow along. And you guys obviously can keep the handout. And it's more informational for you guys. It has our contact information and a little bit about myself as well.
Right. Yeah, my computer's gonna take forever to turn.
Yeah. Okay, thanks. Okay.
Good luck.
The only thing I will ask guys is once I get started, if you guys can, if you anticipate some ambient noise on your end, we'll have you guys mute yourself and then just wave me down if you have a question, and I'll stop. Okay, I'm gonna get started here just to respect everybody's time. Let me just pull up my presentation. I'm gonna share my screen. Okay, you guys can see my screen now?
yes.
Okay, great. Just give me 1 second. I'm going to pull up my. Okay. Welcome, guys. Thank you guys for joining us. I'm trying to make this as interactive as possible so that you guys can get the most out of this presentation as we can make it. My name is Raul Lona, and I'm a physical therapist here at M3 Physical Therapy, and I will be presenting for you tonight. A little bit about myself, and just to go back a little bit, our topic tonight will obviously be on low back pain and sciatica, which I've been lecturing on for the last couple years. We've been doing these Zoom presentations the last couple months, given the times, but normally we do these in person, which makes it a little bit more interactive because I actually pull people up, I do some demonstration on them, I do some adjustments on them, and it makes it a little bit more interactive, but we do the best we can given the times. A little bit about myself. I've been a physical therapist for 20 years now, almost 20 years, I can't believe it. I received my doctorate from USC in 2001. In 2006, I received my orthopedic clinical specialist, which is a board certification for specialty in orthopedics. I've had several publications in low back pain treatment as well as diagnosis. Our clinic itself, we were formerly known as M3 Physical Therapy. We are now we were formerly known as Wilshire Linden Physical Therapy. We are now M3 Physical Therapy for the last 5 years. And our clinic has, because we've been around for so long, since 1981, so that's one of the answers on your questions. We've been around and treating patients with low back pain and sciatica since 1981. We have currently 4, bringing on a 5th physical therapist on staff. We're all specialized in treating lumbopelvic dysfunction. So if you're looking for treatment, specific treatment for your low back and sciatica, this is the place to be. So tonight we'll talk about the sciatic problem that many people have. And specifically, we'll talk first about the sciatic nerve, okay? The sciatic nerve is the largest nerve in your body. And it originates in the lower back. If you can see with my laser pointer here, it comes out of your pelvic region and it travels all the way down the leg. It's this yellow structure that goes all the way down the leg. Okay, it kind of travels down the back and the side of the leg. And the branches of this nerve terminate in the foot and toes. Therefore, when people have sciatica, they may have symptoms not just in your rear end, but also down your knee, thigh, and into your foot and toes. And that's just because of the anatomy that this nerve, as it goes down and travels down the leg, branches off into smaller nerves that innervate and provide a sensation to different parts of your leg. Okay, so that's the sciatic nerve. And that's exactly what gets pinched when somebody has sciatica, is this nerve. So to give you a little bit better description, the sciatica, where it comes from, it basically is a pinching of that sciatic nerve that we just described. And again, the nerve originates from the low back and travels down the side of your leg. Think of it like a garden hose, a kink in the hose. And when you think about when you're watering your plants or your garden, if you have a garden, and all of a sudden you hear a gurgling sound and the water pressure goes down, what's the first thing you think about? You think of something, there's a kink somewhere in the hose, right? So you got to go back and find where that kink is. And once you open up that kink and resolve it, then the water starts to flow easily and the gurgling sound goes away. That's exactly how sciatica works. Somewhere along the path of that nerve that I showed you, there is a kink, whether it's in the lumbar spine, the lower back, which is the most common area, whether it's in the gluteal area or any of the muscles down the path of that nerve. One of those areas could be creating a kink. And like I said, most of the time, and I would say 90% of the cases, it's somewhere in the low back. Now tonight, we'll talk about the different areas, the different problems that can cause sciatica, specifically coming from the lower back or the pelvic region, okay? And just remember the second question here, the sciatic nerve is the largest nerve in the body. Any questions so far? We're okay?
Yep.
Okay. So what are the major causes of low back pain and sciatica? Well, the first and most common one, which we'll talk about first, is a disc injury, okay? So a herniated disc is the most common cause. So think of the disc that's in your spine. It's this blue structure here in between the vertebra, blue whitish structure. It's like a jelly donut. It's like a hard jelly donut. On the outside, it's a hard bread-like surface that's hard, and on the inside there's watery and jelly substance called your gelatinous substance inside of that disc. People who have a herniated disc tend to rupture that donut part of the disc, and it ruptures, which creates the leaking of that jelly outside of that disc and onto the nearby nerve. What do these people look like? These people are commonly between the ages of 20 and 40. So we're talking about a young population. They usually have pain with bending and sitting. The injury is to the outer disc, which again causes a leak to the inner fluid, the jelly, and it causes it to leak out. And these people, what they feel is usually relief with standing and extension. Okay, so if you have pain with sitting, pain with bending, pain with rotational movements, that gets relieved with standing and extension, and you fit this age description and you've injured yourself lifting something, it's usually coming from a disc. Okay? So treatment is depending on the stage that the person comes in with. If they come in with a hot disc that's really painful, they have a lot of inflammation, they have a lot of swelling on the nerve, we're not going to do a whole lot in terms of exercise. We're going to educate you guys a lot. We're going to get our hands on you. We're going to do a lot of manual mobilization, massage, joint mobilization, a lot of ice, heat, and modalities to try to calm things down. We may even suggest, if your doctor hasn't already suggested, is to take some steroidal medications to get the inflammation down, or the non-steroidal medication to get the inflammation down. Again, I mentioned we do a lot of education with these patients. The first and the biggest thing we do is to make sure that they're avoiding bending and twisting. That's the common reason why they get the injury first. So we want to make sure that they're avoiding that to allow that disc to heal. And it can heal. The disc can heal naturally without needing injections, heavy medications, or even surgery. So you're coming to therapy to avoid getting to that stage. Okay, you also want to try to avoid sitting or lifting or any repetitive activities like cleaning your house. Okay, so that's a big common thing that I see is people injure that disc and they're starting to feel a little bit better and all of a sudden they want to clean their house, and cleaning their house with all the bending, twisting, and lifting can really be a big aggravating factor. Treatment, which we'll demonstrate here in a second, is based on an extension-based program called McKenzie. Dr. McKenzie was an Australian physician who developed this treatment approach that really was specific for people with these types of problems. We also, and a lot of times, have nerve mobility issues, which we want to address. Nerve mobility issues is when that sciatic, remember the sciatic is a nerve, when that nerve becomes pinched, the mobility of it is decreased. So we want to get that nerve moving, because if we get it moving and get blood flow to it, it makes the pain reduce pretty quickly. And then eventually, once you get to the stage, we're going to be doing a lot of core strengthening and progressing into more functional retraining to prevent any future injury. Okay, so I'm going to bring my assistant here, or my patient, to help me demonstrate a typical evaluation of a patient with a disc injury. Okay, I'm going to stop sharing, and this is Amanda. Amanda is my patient.
Hi guys.
Amanda, tell me how old you are.
I am 38 years old. I'm a mother of 2 kids.
Okay, and it sounds like you're here for back pain.
Yes.
And is it going down your leg as well?
Yes, it is. It's when I bend and to pick up my kids, it goes down the right lower side of my leg.
Okay, and is there anything that aggravates, you said when you bend and when you lift your kids, that aggravates.
Yes.
Is there anything that makes it better?
Right now, it gets alleviated by walking, and then also when I take Advil, which I hope goes away with that.
Okay, so she's getting some relief with extension like we talked about. She's also getting some relief with some Advil or some non-steroidal medications. So that's a common thing. We want to calm that inflammation down initially to get her moving, allow us to get to the stage where we can start to work on the range of motion and strength deficits that she may demonstrate, and also to get that nerve healing and mobilized. Okay, so Amanda, I'm going to have you stand up. I'm going to have to take you through a few tests to see what your range of motion may look like. Okay, I'm going to have you face your right, good. And then the first thing I'm going to have you do is flex forward and try to touch your toes as far down as you can go, and tell me if that hurts.
A
Okay,
little.
come back up. So this is a quick screen of some tests that we would do in the clinic to verify that this is a disc injury. And let's do it 2 more times, Amanda. And back up. And then 1 more time. Okay, so now was that third one worse than the first one, or is it about, okay, so it's getting worse. So that confirms that flexion is causing the pain. Now put your hands on your waist, Amanda, and then I want you to extend backwards. If you go on, extend backwards, the other way, the other backwards. There we go, extend, extend, extend. Okay, so any pain with that?
A little.
A little bit. Is that better than bending forward? I'm gonna have you do that a couple times. So go back to straight and then backward again. Go back. Okay, and then straight, and then back 1 more time. Okay, how is that? Is that better, worse, or the same?
The same.
Okay, so Is extension, the backward better than the going forward? All right, so that's pretty confirming and telling that's more of a disc injury. She fits the age range. She fits the provocations in terms of bending and twisting causes pain. Now, Amanda, I'm going to have you lay on your back. I'm going to do one quick test on your back to see what the nerve may be looking like. I'm going to move here. And you said it was your right leg, correct? So I'm going to raise this leg up, and you're going to tell me if you have pain when I do this.
Yes.
Okay, so where is this pain?
Down the leg.
Okay, is it similar to the nerve pain that you get down the leg? Okay, I'm going to come back down. Does that start to go away?
Yes.
Okay, and then if I do this, does that make it worse?
Oh, yes.
Okay, so that makes it worse. That's a positive straight leg raise test. People with a disc injury that's compressing on a nerve are going to have that test be positive. So that's one of the things that we look for. So now we have a history, we have range of motion, and we have nerve tests that kind of point toward a disc. How are we going to treat Amanda? Amanda came in with an acute injury that is pretty painful. We're not going to do a whole lot the first treatment. We're going to educate her on what things to avoid. And what things did we mention, guys? We want to avoid the bending. We want to avoid the twisting. We want to avoid any lifting. She has kids, so she's going to rely on her husband to do a lot of the heavy lifting so she can allow that disc to heal. Okay, so, and we also want to start to get her moving. One of the first things I do is I want to put her on her stomach. I want to put her in what we call an extended position. Remember when she was standing and extending back, that seemed to feel a little bit better than going forward. So I'm going to use that and go with what she is more comfortable doing and use that for my advantage and for her benefit as far as healing. So the first thing I'm going to have her do is try to put her on her stomach. And sometimes we may need to use a lot of pillows underneath her hips. So if you have an acute disc injury, we may use a lot of pillows to get you on your stomach. Sometimes I may use up to 4 or 5 pillows, believe it or not, to get her comfortable and able to lie on her stomach. Go ahead and lay your head down, Amanda. And while she's here, I may actually have her with electrical stimulation, with some ice to, again, control that inflammation. I may start to do some soft tissue work along the leg and into the spine, the muscles in the spine to try to get those to reduce and start to get those to start to heal. Because again, it's not just a disc problem, it can also be the muscles are also really tight and also contributing to this pain. So Amanda finished out her first treatment. She got educated on what movements not to do. She got some education on how to put herself on her stomach, and then we're now going to progress to some exercise. So she comes back on the second day and she's feeling better. Her nerve pain is less, her back pain is less. We're going to start to progress her into some more exercises to further accentuate that extension. And the reason extension and bending backward is important is because it actually puts a pressure on the disc. Remember, when you have a disc injury, that disc is pushing backward toward her nerve. We want to create a pressure that's pushing back against that disc to allow that disc to start to heal and kind of situate itself back into position. So I'm going to have Amanda go onto her elbows and bring herself up. Okay, so this is more prone on elbows. Okay. And she's going to hold this position here for about 5 to 10 seconds, and we will progressively increase that time. And I may even have her start to do some reading or check her phone here in this position for several minutes at a time. Again, to start to get that extension force to push that disc back into place and allow it to heal. Once she's able to do this pretty easily, then we're going to progress this exercise into more of an extension-based exercise. So Amanda, go ahead and push off, so straighten out your elbows. And she's going to go more into what we call a upward-facing dog, if those of you guys are familiar in yoga. And again, it puts even more pressure on her spine. It creates more force to push that disc back into position where it needs to be. Okay. She's going to hold it for a count of 20 to 30 seconds, and she's going to repeat that several times during the day. I'm still educating and telling Amanda, avoid bending, avoid twisting, avoid lifting the kids. Come back down, Amanda, take a break. Okay, so she came back for her 3rd and 4th treatment. She's feeling 50% better. Some of the symptoms in the leg are starting to go away. It's becoming more concentrated in the hip. That's a good sign. That means that her symptoms are centralizing. That means that that nerve is healing. That means that that kink that we identified as the disc causing pain on the nerve is starting to resolve, and it's starting to open up. It's allowing her to do more. She's telling me that. How is your sitting these days, Amanda?
Longer periods of time.
So she can sit for longer periods of time before that pain comes on. Okay, so Inflammation seems to be going down. Her range of motion is better. Let's get into some strengthening. Amanda, I'm going to have you, you're still on your stomach. I'm going to have you raise your leg up one at a time in this position. So go and raise. So now we're getting into some strengthening of her muscles in her back, and lift the other leg. Okay, progressively increasing. Now go both 2 legs at the same time. So squeeze your glutes, squeeze your abdominals. Now you're lifting. And then to make it even harder, go ahead and straighten your arms out and your legs at the same time and hold it for a count of 5. So 1, 2, 3, 4, 5, and back down. And one more time. 1, 2, 3, 4, 5, and back down. That is a typical progression, guys, for somebody with an acute disc injury where we want to get her pain and inflammation to go down and get her to the point where she's doing some strengthening and some range of motion exercises, because that is ultimately the most important thing that she's going to need, is to get that range of motion back and to get the strength going in those muscles that have become weak because of the pain. And as we're doing this, we're helping that disc heal. Several studies have shown that MRI before, when the disc is acutely injured, and then after they've gone through a regimen of physical therapy, that disc can actually heal and position itself back into position where it needs to go, and of course, take the pressure off the nerve. Okay, so Amanda, I'm gonna have you come on up, and she is gonna be discharged for today. She did about, the typical treatment for this type of problem is between 8 to 12 visits, about 4 to 6 weeks, depending on how acute the injury is initially. And we normally see people twice a week for about 6 to 6 weeks, okay? So that's usually the typical course of treatment for this type of problem. Okay, I'm gonna stop here and give you guys a chance to ask some questions. I'm gonna stop sharing my screen too. Okay, anybody have questions so far? Anybody have anything they wanna comment in terms of their particular issue that they're having with their back? Any questions you want me to clarify? That's good. Okay, now's the time to do it, guys. It's a pretty small group, so I can really get to a lot of questions pretty quickly.
Yeah, I have a question. I have
ahead.
a bulging disc to the left. I've had an MRI. I have a 5 to 6 millimeter bulge.
Yep.
Sciatica, left side. I can't seem to sleep or get out of bed or even roll out of bed. I don't know how to even do that. I hold on to the wall, I push myself, I pull on my bed sheets. I'm just trying to move and try to, is it better to have a mattress that's like softer or firmer when I have this back injury, which is a work-related back injury that I'm suffering from?
All right, tell me your name again.
Melanie.
Melanie. I tend to prefer the firmer mattresses. I think they provide more support. The soft ones, especially for a disc injury, tends to be not a good thing. It tends to aggravate things very easily.
Okay, because I bought a memory foam that I thought was going to help me, 3-inch.
Yeah.
And I sink in and I'm very comfortable, but
you wake up sore.
I can't sleep.
I think the safest way to go with mattresses, I'm not the expert at them. A couple that are out there that have some research behind them are the Sleep Number mattresses. Those are the ones that have the bladder that you fill up the air. And I always tell people, buy a good firm mattress. Even if it feels too firm, you can always add those padded, foam, liners that you can put on them to make them a little softer. But I, again, think that a more supportive, harder mattress tends to be better for back pain in general. Not necessarily for a disc, but just back pain in general.
Okay.
Okay. And it looks like, how old are you, Melanie?
I'm 60.
60. So you're going to fall probably more into you're going to fall into probably a couple of different categories. Remember, I talk about this in isolation, but a lot of times people have a disc injury and they also have a problem with arthritis and stenosis, which is what I'm going to talk about next. Okay. Mm-hmm. So you may have a couple things going on just based on your age. Unfortunately, as we get older, things tend to wear down and we have more problems with arthritis. So I'm going to share my screen again, and we're going to get back to our presentation. So I went over the typical progression for treatment of a person with a herniated disc in terms of managing the acute symptoms and the progression of exercises and getting the nerve moving and eventually working on strength and function. Okay. So next, what I want to get into is, Okay, so the next common cause of arthritis or stenosis is of low back pain and sciatica is a stenosis. Sometimes it's known as arthritis. Sometimes you're going to see DJD, DDD, degenerative joint disease, degenerative disc disease. All of those are pretty much a fancy term for back arthritis or degeneration of the spine. And this is what a spine would look like in somebody with arthritis. You can kind of see that it just looks like an older spine, right? The bones are a little bit more worn. You see some osteophytes, some calcification. You also can see here that this white thing here, this is the disc where my laser pointer is moving on. And then if you look down at the next segment, what's the difference between this disc and then this one here?
It's narrow.
It's really narrow, right? It's really flattened out. And that's typically what happens with somebody with arthritis in their spine. That disc tends to wear out. Remember that jelly that I talked about? All that jelly kind of seeps out of your disc over time and it flattens out. And over time, you start to lose height because you lose the height in these discs that are pretty plump, and sometimes, they could measure a couple millimeters in height, maybe 3 or 4, maybe 4 or 5 actually. And if you start to lose those millimeters in height, you have about 27 vertebrae in your spine. That's a lot of millimeters to lose if you lose height in each one of those discs. So you start to get shorter. Some people shrink as much as, 5 inches in their lifespan. So it is the common cause of why people lose height as well as why people have arthritis. So that disc creates plumpness in between the vertebra, but it also creates space. So you can see the space on this segment here is nice and patent to allow that nerve to exit. When you get to this space here where that disc is flattened out, there's not much space for that nerve. Here is the kink of where people have this problem. So what do these people look like? These people are usually, they have more than 50 candles on their birthday cake. They have pain with standing and walking, which is the opposite of somebody with a disc injury, right? We talked about previously. These are the people that you're going to see at Costco or at Target, that they're leaning on their carts to bend forward as they're walking. They're going to be leaning on their walkers or whatever if they have. Just because what it does, when you lean forward, it opens up the space in the vertebra to take pressure off that nerve. Okay, so this is a problem of loss in space in the spinal column. These people are going to get relief with bending and sitting. Okay, so again, opposite of what we had with the disc injury, these people are going to get more relief with the opposite things as well. Okay, so again, we manage the symptoms based on the acuteness of it. If they're really hot and inflamed, we're going to do a lot of modalities, a lot of manual massage techniques, electricity to get the inflammation in muscles to calm down. Again, a lot of education to decrease right activity. We may even suggest for you guys to start walking in a pool, which is going to deload the spine, create some space, and take the pressure off the nerve in the disc or nerve in the spine. Promote more flexion positions on your back or in sitting. And then sideline positions to promote the joint to open. Sometimes traction can be effective for these patients, and again, nerve mobilizations. So I'm going to have my assistant come back here and demonstrate what a patient typically would look like for this. Oh, it's Amanda again. Actually, this is a different person. This is Mary. Hi, Mary. How are you?
Hi.
So what's your problem today, Mary?
I'm a retired teacher who has back pain without any injuries, and it's in my low back that radiates down both my legs.
Both legs. Okay. And how old are you?
72.
72-year-old. Okay. And tell me, how did you hurt yourself?
No injuries.
No injuries. So this is typical. This problem is going to come on insidiously. With the previous person, she bent over to pick up her kids and hurt her back. With these types of problems, the pain is going to come on pretty insidiously. I mean, there was really no cause. It gradually came on. She also said a couple key things, that the pain goes down both legs. And that's pretty typical with these problems, with arthritis. The pain will go and radiate down both legs because the vertebra has degenerated and both sides of the spine has created compression on those nerves. So the kink is that arthritis and that narrowing of the space on that nerve. Okay, Amanda, I got enough history from you. Mary, I'm going to have you stand up. I'm going to have you face that way. And then go ahead and bend forward as far as you can again. Okay, and then come back up. How did that feel?
It's okay.
Okay.
A little pain.
Little pain, and then come back down again, and then you'll let me know how. I'm gonna have you do that one more time after this one, and then come back up. How does that feel? Okay, fine. And one last time. And is this, you went down a little further that time. Is it getting better? Okay, so
Bending forward makes it better.
good. So opening up the spine and creating space for that nerve to flow out of the spinal column is creating relief in her symptoms. Now that you're standing, how does it feel here?
It's okay.
It's okay. Is the pain starting to come back?
A little.
A little bit. Okay, so the pain is coming back a little bit. She's in an erect, extended position. Again, she's narrowing those vertebrae that were compressed and narrowing them further and creating more pain on that nerve. Now extend back, Amanda, and extend your spine backwards. Okay, how does that feel? Painful. Okay, so that's causing more pain. All right, so I saw enough with range of motion. I don't want to make you any worse. Amanda she's in pain, but she's not in a ton of pain, so I may go right into exercises with her. Amanda, I'm going to have you sit down, and I'm going to tell you, Amanda, because you said that you wrote on your sheet that you do a lot of walking.
Yes.
I'm going to tell you, you may want to stop walking for a little bit. Do you have a stationary bike at home?
No.
No? Okay, you might want to either borrow a stationary bike. Once the gyms open up after COVID, that may be an option for you to start riding a bike instead of doing so much walking. Because again, walking is going to create that compression on your spine. And for somebody with arthritis like you, that may make things worse. Let me give you a couple stretches to start working on here so you can start to open up your spine. I'm going to have you flex forward now that you're sitting. And again, this is promoting a flexion position of her spine, starting to get things to open up and allow that nerve to have some space. And we may do this several times during the day, okay? And then come back up. All right, and one more time. Good, and she's gonna hold this several times, allow your head to drop. That way the gravity of your head will allow the spine to flex even further, and then come back up. Okay, that's one exercise I want you to start doing, Mary. Now I'm gonna have you lay on your back. Okay, and then what I want you to do is grab your knee, pull it toward your chest, and then grab the second knee and pull it toward your chest again, and then pull and hold. Again, this is a flexion position that is creating space and opening up the vertebra in her spine to take the pressure off the nerve. Okay, so I'm going to probably give her that the first day she goes home. She's going to come back and she's going to tell me that her pain is a little bit better. She maybe has less pain going down the legs and the nerve is a little bit less irritable. We're going to get into some strengthening. The first one I'm going to do with her is to do some bridging exercises to, again, start to strengthen those muscles that are so important. I'm going to have her squeeze her glutes and start to lift her pelvis just a little bit and then come back down. And then squeeze her glutes and lift a little bit and come back down. Now as she starts to get stronger, more comfortable, more mobile here, she's going to start to go up a little bit higher and she's going to start to challenge her muscles a little bit more in her glutes and in her back, which again, very important. These muscles directly attach onto that vertebra that is degenerated, and it helps to stabilize that spine. One more here, and then come back down. So in her third or fourth treatment, maybe third or fourth week, we're going to progress this, again, bridge again, Amanda, and then hold that there, and then start to march your feet one at a time. Good. Now keep that pelvis level like we've worked on. As you're marching, again, progressing the exercise intensity to, again, continue to strengthen those muscles and then come back down, okay? And then go ahead and pull the knees toward your chest. And good. Now I'm going to give you one more exercise, and that's going to be a nerve glide. Remember we said we want to get that nerve moving when it is pinched and it's starting to calm down, but it's still giving her symptoms down the leg. We want to get that nerve moving because mobilizing that nerve, and we're not going to stretch the nerve because nerves don't like to be stretched. We're going to get it gliding. Think of nerve like the floss that you floss your teeth with. It is hard. It doesn't have any give to it. That's exactly how nerves are. They don't have elasticity in them, so therefore you can't hold them in a stretch position. To get them to heal and to start to move better, you want to glide them. So, man, I'm going to have you straighten this leg out and then pull that thigh toward you a little bit. Good. Hold the back of your thigh and then straighten out that leg and pull your foot back. And then once you feel that stretch, I want to bend your knee and come back down. I'm going to have you do, bend your knee and just, there you go. And then straighten out the knee and then pull the foot back. Good. Bend the knee, point the toe. And she's going to do that continuously for a minute, several times during the day. And what this is doing, again, it's gliding that nerve forward, up and down her leg to, again, get it to heal, get it to decrease in pain, and again, take pressure off of it, which is going to make her more comfortable for those symptoms that she's having in her leg and down into her foot. And she's going to continue that for a minute. We will get more aggressive with the nerve mobilization as her treatment continues and get more aggressive with the strengthening. Teach her how to move, teach her how to avoid provocating movements like extension and a lot of walking. We do want you to walk, but we're going to modify it a bit until your muscles in your back and become more supportive and strong, and until that nerve starts to calm down. So that's going to be a typical progression for Mary. We're probably going to see Mary 1 to 2 times a week. She's going to heal slower. Unfortunately, as we age, the healing process also slows down. So we may see Mary for about 6 to 8 weeks, and it may take maybe more 14 to 15 treatments to get her back into doing the things that she wants to do. Okay, so typical progression for Mary, and hopefully we are able to help her, which we do. Again, we've been treating hundreds and thousands of patients in our clinic since 1981 for low back pain and sciatica. Okay, I'm going to stop here. Any questions right now at this point?
Yes, this is Tiffany. Can you hear me?
Yeah, go ahead, Tiffany.
Yeah, so I have a question. Can this sciatica problem, after physical therapy and stuff, will it go away or it will come back if you keep, like, a lack for of the better word is abusing your body? I mean, once you have it, can you somehow treat it and permanently get rid of it?
Yeah, absolutely. Many cases in our clinic, many studies have shown that exercise tends to be the best and most effective long-term treatment for back pain and sciatica. I mean, you could get the which I'll talk about in a second, the quick fixes, the Advil and the injections. Those things are temporary. They're not going to give you long-lasting effects. They may give you that quick, initial relief because it gets the inflammation down, but it's really the exercise, the retraining the body mechanics, and the increase in flexibility, range of motion. All those things are what changes tissues to take pressure off and, again, relieve that kink that we've been talking about all night, to take the pressure off the nerve and get you living pain-free and get you back to doing the activities that you want to do. For Mary, it was return to walking and exercising. And for Amanda, the first person was to get down and play with her kids, and maybe even to pick up her child. She's got young kids. So yes, the answer to your question is yes. We have many cases in our clinic and in the literature that says that effective physical therapy with specific evaluation, which I try to show and demonstrate tonight, and with specific treatment can be helpful in not only curing back pain initially, but preventing it from coming back.
Okay, thank you.
Yep, absolutely. Okay, I'm going to move on back into my presentation. We're going to talk about one more common cause of back pain, and that's going to be so this was the evaluation and treatment of patients with stenosis and arthritis. So the next common cause of back pain is a sacroiliac joint dysfunction, or SIJ, sacroiliac joint. And that's with the pelvis and some of the muscle joints in the back, in the pelvic region. So your pelvi are two bones that come together in the back and form a joint with your sacrum, called your sacroiliac joint. It's these red hot spots here where my pointer is here. That's your sacroiliac joint. This is a common cause in the clinic for back pain that is commonly missed. A lot of physicians and other healthcare providers don't believe that there's an issue here. But again, we've been doing this for almost 40 years, and we've seen hundreds and thousands of patients with this problem. And this is the one problem that can be fixed rather quickly. Unfortunately, it gets missed a lot in other clinics and other provider offices. So we're able to provide help pretty quickly with these patients. What do these patients look like? They're usually typically between 13 and 80 years old. So the age range is not very specific. We have some very young patients, and we also have some very much older patients that suffer from this problem. Again, it's an obliquity of the pelvic bones within your hips that causes a strain on the ligaments. So if you can visualize, this bone here rotates back on the right, and on the left here, it rotates forward. Okay, so this is a view looking at the patient from the back. Okay, so this is a rear end you're looking at, and this is just looking right through those muscles and tissues, looking at the bones. So there's a rotation that creates here. Usually, commonly, what happens, what causes that rotation is a fall injury. Again, many people tell me that they slipped on a wet surface, or they've gone snowboarding or skiing, and they've fallen and they've landed on their rear end. And when that happens, it creates a rotational force on these tissues, creating this rotation of the pelvis. Females are more likely than males to have this problem, simply because the pelvic and hip joints are much more mobile in females than they are in males. And again, that's for birthing purposes. These people tend to have pain with transitionary movements, with sit to stand, twisting movements, getting in and out of their car. People who sit a lot for a living tend to have this problem because they're sitting on a sit bone that is rotated, and that creates a lot of irritation. Okay, and again, these people usually report that the pain is pretty pinpoint. If they tell me, if I ask them, where is your pain, and they point to this area right here, I know that it's likely a sacroiliac joint problem. Okay. So again, managing these symptoms is to normalize. The first thing I do, no matter if they're acute or if they are chronic, I normalize the alignment in their pelvis, which is manual therapy, which I'll demonstrate here in a second. I'll work on a lot of the soft tissue tightness that they have, or even get that nerve moving again. Similar technique that we demonstrated earlier. Again, improving strength and flexibility is really, really important. And then progressing them to a really strong exercise program to get the muscles around those muscles and joints to stabilize. And again, like Tiffany said, how do we prevent this from happening again? Well, we got to get the muscles around the problem area, around the kink, strong so it doesn't continue to shift out of place. So I'm going to bring my assistant here back again, and she's going to help demonstrate an evaluation and treatment of this problem. So now we have here, Sarah is joining us today. I'm going to stop sharing my screen. And here is Sarah. Hi, Sarah. How are you?
Good.
Sarah, how old are you?
I'm 45.
45. And what are we seeing you for today?
Lower glutes and back hurt. I fell while snowboarding with my kids.
Oh, okay. How long ago this happened?
About 6 months ago.
Okay. And then tell me, can you point to where your pain is? Right in this area. Okay. So more here. She's pointing kind of to her gluteal area right in the back. Given her age, given what she is describing, I'm going to go ahead and assume this is a sacroiliac joint issue. In the state of California, we do not need a prescription to see patients with low back pain or really any pain. We are licensed to see patients literally off the street with any kind of pain problem for about 12 visits or 45 days, whichever comes first. Now for Amanda, I'm going to bring this a little closer. I'm going to assess the alignment and posture of her, for Sarah, I'm going to look at the posture and alignment of her pelvis and see if it is straight. Remember we said with this type of problem, there's usually a rotation that occurs. And Amanda actually, and Sarah, she actually does have a problem with rotation. She's got one left on the back and the right one is forward. So it looks something like that. Okay, so left one back, right one forward. And I'm going to go ahead and mobilize. I'm going to actually have her just do a quick test of flexibility here. So tell me that as far as it goes. So what happens there, Sarah?
I feel the pain down my leg.
All the way down the leg. Okay, so again, there's a nerve that goes right by that sacroiliac joint, so that's irritated. And we're going to take this one up. So that hurts the same thing?
Yes.
Okay, does this feel different than the left side?
Okay, no.
Okay.
Range of motion, yes.
The range of motion was that. Okay, so I'm going to raise up the table. I'm going to do a pelvic mobilization, which is typical manual treatment that we would do for this type of problem. I'm going to have Sarah turn to her side facing me. Pardon the view here. I'm going to have Sarah scoot forward here. Good, right there is fine. And I'm going to literally get in between her legs, and I usually will preface by telling them, especially if it's a female, I'm going to position myself in between your legs and create like a split position of your pelvis and legs. And I'm going to mobilize your pelvis to try to get it back into position. So I'm going to flex here, position myself here. And I've actually done this with Sarah before in the clinic, so she should be somewhat familiar. Sarah, when I ask you to, you're going to squeeze me like a scissor squeeze in between like that. Okay, so here, now squeeze, let it go, squeeze, let it go, and squeeze, let it go. Good. And then once we've mobilized that pelvis, attempt to put it back into position. Open up your knee, open, 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 open. Now hold. We're going to go through a series of strengthening exercise. We're going to open up a little harder. Now hold right there. Hold, hold, hold. Let it go. Again, open. Hold, hold, hold. Good. Now let's do the opposite. Squeeze, 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 squeeze. Let it go. And one more time. Go a little harder. Don't be afraid. Go, 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 go. And let it go. Okay. So I'm going to do that on several muscles of her leg. We're going to do the same thing on the other side. Okay. I'll never forget the story of a patient that I had who I did this to. She was a very nice woman several years ago. She was Orthodox, she was Jewish, and I knew that. I needed to do this technique on her because this is the problem that she had. And I was kind of afraid to do it because I just didn't think that she'd be up for it. But I told her, listen, I'm going to do this. Is it okay? She said, honey, whatever you need to do, go ahead and do it. So we went ahead and did it, and we did it for several weeks until things were back into position. Go ahead and hold your leg here, Amanda. Now squeeze, let it go, squeeze, let it go, and squeeze, let it go. Okay. So after about 4 to 6 weeks of treatment with her, she worked really hard in the clinic. Open up your knee. Open up your knee again, and we're going to keep working on these muscles. After about 6 weeks of treatment, she was better. On her last visit, she brought me a box of cookies and a card. I opened up the card, and it said, what do you say to the guy who you've had between your legs for the last 6 weeks? Thank you. You really helped me. It was just a card that I'll never forget, very witty. But anyways, that treatment tended to really help her because it really mobilized that pelvis. It got things back in position. Go ahead and lay on your back, Amanda. And it relieved a lot of the pain off of the nerve. Go ahead and lift and back down. Straighten your legs out. Good. And we're going to reassess that pelvis. It looks a little bit better actually than it did in the beginning. And then let's raise the leg up and reassess. Okay. It's able to go a little bit higher, even though she's still getting that stretch. So range of motion of that nerve increased just a bit. And that may happen pretty quickly. Again, these patients tend to get better fairly quickly. And once the pain goes away, then we're really working on a lot of strengthening to keep that pelvis from rotating. Again, because that's the biggest problem, is that a person with sacroiliac joint dysfunction will exhibit that rotation of the pelvic bone, which is the answer to your last question. Okay, so I'm going to go back to my presentation here. Okay, so we talked about 3 pretty common injuries to the back that can cause a low back pain and sciatica. We've tried to talk about not ignoring, and what are your options in treatment? I mean, there's a lot of different options out there for this type of problem. Chiropractic, physical therapy, injections, medicine, acupuncture, many, many different ways to treat and approach this. What I will say is go to a practitioner that really gives you a specific evaluation. I've tried to demonstrate here with my assistant Amanda, Sarah, and Mary, in terms of I really evaluated her. I listened to her problem. I knew her medical history, and I got really in depth in terms of what her problem was. I did a thorough evaluation. And in our treatment, in our clinics, you're going to spend about an hour with a doctor of physical therapy that is really trained and been treating patients for sometimes more than 30 years, believe it or not. We have some therapists that have been doing this for about 30 years. And you really get specific in terms of diagnose your problem so they can administer the appropriate treatment. Remember what we said, you have to identify what the kink is in the low back that is causing that pain or that is causing that sciatica. And the only way you can do that is to really do a thorough evaluation with these. Okay, so treatment-wise, the options are you can ignore the pain, right? You can just say, hopefully this goes away and I don't have to, inconvenience myself to try to get treatment somewhere. You can alter your pain, which is, taking Advil, doing injections, which is just going to be a temporary fix, or you can handle the pain by getting it thoroughly evaluated, specifically evaluated by a professional that is going to implement specific treatment based on what the problem is, based on where that kink is coming from. Delaying your treatment can cause an increase in healthcare costs downstream, which means that the longer you wait to treat this problem, usually the worse the pain gets, then you need to get an MRI, then you need to get an injection, and all these unnecessary things that if you treat the problem right away and get to treatment and physical therapy specifically, you can reduce those costs and time by thousands of dollars downstream. So the point of tonight is get a specific treatment, by getting a specific evaluation, and don't ignore the pain, handle the pain. Now, we, as I mentioned at M3 Physical Therapy, have treated thousands of these patients. We've handled many, many cases for the last 40 years. We consider ourselves expert at what we do. We offer in our clinic evaluations. We work with most insurances, and that's the quickest way to start making you feel better, is to get an evaluation. If you're not ready to spend your insurance dollars or you're not quite certain, we also offer free screens, which are no strings attached, a screen for 30 minutes with a licensed doctor of physical therapy. Again, usually someone that's worked with patients for over 30 years, 20 to 30 years. And they can start, looking at you and seeing if there's a problem, or if your particular problem is something that we can treat, and let you know what we can do to help you and how long it may take to get you back to living the life you want to live. So a couple different options. Evaluation, we're going to evaluate you thoroughly like I did tonight, and get you treatment the first day, and start getting you back to living pain-free and getting you back into doing those things that you want to do. Mary, Amanda, and Sarah's case, it was, walking, with getting back to their walking routine, picking up their kids, getting back to snowboarding and so forth. So everybody has a certain thing that they want to get back to doing. It's not just about alleviating the pain. It's really about getting back to that function that they've lost because of the pain. So that's what we do. And that's how we train you to get back to doing those specific things. So I encourage you, if you do have back pain, sciatic, please handle it. Don't ignore it, and take care of it today, and consider coming to see us at M3 Physical Therapy. I'm going to stop there, or I'm going to put our contact information up so you guys can have that. And our information is here. We have clinics in West Hills and one in West LA. Our website is there. My contact information is there in case you have specific questions that you want me to answer. Our phones are open. We still have some receptionists here if you guys want to give us a call and schedule an appointment so that you guys can start getting treatment right away. I'm going to close here. Do you guys have any questions that you guys would like me to address? I didn't quite, there's a third person on here. I didn't quite catch your name.
Yeah, Usha. Can you hear me?
Oh, hi, Usha. How are you?
Good, thanks. How are you? I have again I saw you before, last year.
Yeah. No, that was 3 years ago, believe it or not.
Last year in August.
Okay.
So, but again, the problem is with the lower back pain.
Okay.
And then on the left side, from knee to the toe, it goes. And then I saw Dr. Lala. And he gave the injection a week ago, but it's not helping much. When I walk, my back hurts, but now I start wearing the belt, and that belt helps me in walking. I don't know if it is the right to have the belt, wear the belt or not.
And if the pain is acute, I will sometimes recommend a belt just to kind of help stabilize, but I tend to try to wean that off pretty quickly, because what the belt does is it makes those muscles that we talked about tonight weaker, and then the pain may not resolve completely. And I do remember you. I think we saw you 2 to 3 years ago.
Yeah.
I remember you got some good relief, but it's sometimes with arthritis, which I think is what.
Yeah, because it is arthritis, and the
lunch in there.
Doctor says there are
let's see how
nerves at the back, and that maybe the knee pain is due to that.
Yeah, it could be, and you may need to come in for some tune-up
to
get you back to where you were before. Because I remember you did get quite a bit of relief when we saw you before.
Yeah, maybe let me see I have to see Dr. Lala again next week, and after that, let me know what he says.
Okay, sounds good.
Okay.
Anyone else have any questions? Good seeing you, Usha.
Thank you.
This is Tiffany. Do you accept Kaiser or no?
We're not in network with Kaiser. We don't have any contracts with Kaiser, unfortunately. They're pretty exclusive to their therapists. We do have a lot of patients that come from Kaiser because they're not happy with the treatment that they get,
Yeah.
and they just pay out of pocket, Tiffany. But we have several packages and treatment, payment plans that we can work with you to make it more affordable for you.
Thank you.
Mm-hmm. Melanie, you doing okay?
Yeah, I'm doing okay. I was actually doing the exercises with you.
Oh, good, good.
I was on my bed doing that.
I looked like you were doing something there. Any questions or anything you wanted me to address?
No, I'm just trying to relieve some of my pressures in my back, and I know my problem. I've had an MRI, so I'm just trying to relieve. I am not working due to the coronavirus right now, but I was surprised that I had a flare up of my sciatica that I thought had went away. Pretty much went away. I had an injury in December, end of December, had physical therapy, maybe February and March. Everything was good. And my sciatica has flared up again. So I was just going to see if I could maybe get some exercise, do at home, maybe try to see if I could get back to where I was, where the sciatica was gone.
Yeah.
So I guess mine came back.
Right.
And I haven't done too much.
Yeah. That's pretty common, Melanie. A lot of times people start to feel better and they stop doing their exercises and some of the things that we discuss. And just sometimes they need a tune-up, kind of like Usha. She needs more manual therapy. She needs to get back in here to, calm things down. But again, evaluating it is the key thing to see what's going on with you. And that's something we can certainly do for you.
Okay. Thank you.
Okay. It's something that, again, sometimes the exercise may not be right at that moment. Maybe you stop doing them for a while and you're really acute now, and those more aggressive exercises may not be appropriate for you at that point. So it's almost like finding where you are in the continuum of pain and healing, and then addressing that particular point in pain with the appropriate treatment and exercises. So you may need a refresher, or maybe seeing a physical therapist to see if we can to figure out where you are at that point to kind of most efficiently help you.
Okay.
Okay.
Thank you.
Absolutely. Anybody else have any questions? We're here to help, guys. We are taking all precautions to, if you need to come into the clinic, we're cleaning very thoroughly. We're all wearing masks and PPE equipment. We screen all of our patients with temperature and questions. All of our therapists get screened. All of our workers actually get tested every month for COVID-19. We also offer virtual visits, virtual evals via Zoom, in case you just can't come into the clinic for treatment. So I know that there's issues right now with getting into the clinic. But again, we have a very safe environment, very safe and healing environment, and we are here to help you.
Okay. Sounds good.
Thank you.
Sounds good. May see you personally.
Sounds good, Usha. You guys have all my contact information on the handout there. If not, make sure you write it down on the screen. And I look forward to seeing you guys in our clinic.
Okay. Thank you so much.
Thank you.
All right, guys. Good night.